So Sonja Pelzmann will present on splinting in Dupuytrens and is it evidence-based practice? Thank you.
So, thank you for the opportunity to talk about splinting in Dupuytren. There is no conflict of interest. Although splints are the most used hand therapy method in Dupuytren, the following questions came up again and again. Which splint models are used and which one is the best? Are they used as part of treatment or also a sole treatment option? At what interval and for how long are they worn? What relevance does the previous intervention have? When? And what outcomes are achieved with it? So, are splints evidence-based therapy? Therefore, the purpose of this analysis was to show the existing evidence and examine the effect of splinting in Dupuytren disease. Multiple electronic databases and relevant journals were searched systematically for available information. The included studies were classified using the Oxford level of evidence, as well as the Structured Effectiveness Quality Evaluation Scale score. The 47 included studies were published between 1987 and 2025. The sample was between 1 and 659 patients. The level of evidence and the CQ score ranged from 1A to 5 and from 6 to 39 respectively. The second figure also shows that primarily controlled trials followed by expert opinions dealt with this topic. Splints were used after various interventions. They were used after fasciectomies, the McCash open palm technique, needle aponeurotomy, or collagenase injection treatment as part of treatment. Some publications simply stated that splints were used after various or unspecified surgical techniques. But splints are also mentioned as a conservative treatment option for this condition. The authors mentioned different splint models as part of treatment after fasciectomy. This list, which does not claim to be exhaustive, is nevertheless very representative. Both dorsal and volar extension splints were used, some of which also included the wrist. However, there were also reports of the use of dynamic extension splints. Patients received the splints between the 1st and 20th day after fasciectomy. In the first 2 weeks, the splint was usually worn the whole time without tension to help the wound to heal, among other things by positioning the MCP's inflection. Following, the splint were only worn at night time for a period of 2 to 6 months. It was also noted in the publications that other, mostly therapeutic methods, such as exercises, mobilization techniques, or wound and scar management were used in addition to splints. Most of the included studies had a level of evidence of 4 or 5. The results on range of motion were statistically significant at the 2-month follow-up, the 3-month measurement, and the 24-month follow-up, but were otherwise not statistically significant. The measurements of hand function were statistically significant at the 3-month measurement, but not at the other follow-ups. Grip strength showed no statistical significant differences during the observation period. The results regarding scar formation were statistically significant at the 3-month follow-up. Following the previous McCash open palm technique, a wide variety of splint models were also used, including those with flexed MCP joints or dynamic splint models. The splinting treatment started between the 7th and 20th day after the surgery. In the first 3 weeks, the splints were worn all the time. After the 3rd week, the splints were only worn at night time. Here too, the duration of splinting treatment varied up to 6 months. Additional treatment options like exercises, mobilization techniques, or standard information were also mentioned in the publications. The majority of the included studies had a level of evidence of 4. According to the McCash open palm technique and splinting treatment, statistically significant differences in hand function were only found after 1 year. Sole results regarding splinting treatment weren't available. The outcomes at the 3-month follow-up regarding range of motion and hand function and at the 1-year follow-up regarding range of motion were not statistically significant. As with the others already mentioned, there was also a wide range of splinting models available, which were fitted immediately after the needle aponeurotomy and were initially worn for 24 hours. The splinting treatment here also varied in duration, lasting up to 9 months. The patients also received instructions on how to perform exercises. The level of evidence of the studies varied. Only the 3-month follow-up showed statistically significant results in range of motion, which were not statistically significant after 9 months. However, a large proportion of the patients stated that their satisfaction was rated as excellent or good after almost 4 years. At the median 45-month follow-up measurement, 58.5% of the patients experienced a recurrence of the disease. In addition to splints that primarily hold the hand in extension, it could be observed that finger splints were increasingly being used after CCH injection treatment. Splinting treatment here started immediately after manipulation by initially wearing the splint for 24 hours and then only at night time for varying length of time. In addition, various hand therapy methods were also used here. Most of the studies had a level of evidence of 4 or 5. Only the range of motion and the PIP range of motion measurements showed a statistical significant difference after 2 months, whereby the results of the PIP range of motion were also significant at the 3-month evaluation. No statistical significant results were observed at the other time points. After 1 year, 92% of those affected stated that they were satisfied with the result. The included studies also showed that different splints models were used as a conservative treatment option. Aspects such as tension or compression, which were exerted by the splint and should have an effect, were also investigated. The splints were worn continuously for between 6 to 20 hours, mostly during nighttime, for a period of several months. In addition, the patients performed exercises and/or mobilization techniques, for example. The level of evidence ranged from 2 to 5. These results showed that at all follow-up measurements, statistical significant improvement in extension deficit and range of motion. There was no statistically significant differences in the comparison of whether the tissue is more positively influenced by tension or compression. The results of this grouping were primarily based on expert opinions. The authors of the studies reported that in addition to different splint models with a different start and varying duration of treatment, a variety of additional therapeutic interventions were part of treatment. The results showed that statistically significant results were only reported for the evaluation of hand function after 1 year. The other parameters were not statistically significant at the specified measurement time points. So, splinting treatment always takes place in consultation with the treating surgeons. However, authors have stated that there is no right or best splint model. The results also do not allow a general statement to be made as to when, how, and for how long splinting treatment should be carried out after the corresponding previous surgical intervention. The factors that must be considered are the patient's need. This means the splint should be clear and easy to handle and should not cause pain, as well as should be adaptable again and again. The presentation of the characteristic symptoms and this Dupuytren history of each individual patient, which can also have an influence on the splint model or handling, is also important. Ultimately, the possibilities, skills, and creativity of the therapist have also an influence. This is because a nice and comfortable splint, so far as possible, is preferred. Non-adherence and non-compliance can also play a role in addition to the fact that patients do not necessarily want to wear a splint for a long period of time. Most of these results and effects of splinting treatment were mostly described with those of other interventions, surgical and therapeutic ones, and therefore it is not possible to clarify exactly what effect the splint have. Regarding parameters which were collected here, it should be noted that the extension deficit is collected in different ways. It was also pointed out that it is too early to track aspects such as growth strength after 3 months, as improvement is still possible. Furthermore, loss of flexion in surgery is common in patients with Dupuytren. In addition, some authors of other studies mentioned that the dash, which is often used to assess the hand function, is not appropriate or sufficiently valid in Dupuytren. The included studies, those evidence were of low quality and mostly small sample sizes, showed a variety of splinting models as well as treatment option used. Due to the mostly common results, it is difficult to determine and present the true effect of splinting treatment and thus to create or present evidence. This analysis shows a tendency that sole splinting treatment has a positive effect on clinical expression of Dupuytren and suggests there be a relevant role for splinting in treatment of this condition. Thank you.
Any questions? Any questions from the audience? Yes.
If you would have to undergo Dupuytren surgery, would you
I talk with the treating surgeon. But, and then the following time, I talk with the patient. And when the extension deficit or the scar is not so fine, so elastic, so I recommend the patient that he should use the splint longer.
I have a question about preoperative splinting, and I'm wondering, in any of the studies earlier in the ultrasound talk, and looking at that inflammatory process in Dupuytren's, I'm wondering, were there any conservative, so pre-surgical splinting studies that used ultrasound as a measure to see if there was a driver of inflammation from that tensioning to try and decrease flexion contracture?
Pardon.
Sorry, I speak very quickly, don't I? Beg your pardon. So there was a talk this morning on ultrasound.
Yes.
And using ultrasound
Yes.
to identify inflammation in Dupuytren's.
Yes.
In using splinting pre-surgically to try and stretch the joints, I'm wondering, has ultrasound been used to see if we're possibly driving the Dupuytren's disease, increasing inflammation by tensioning the surface?
The most important thing is to have only a very low tension for a long time. Then the fibers can recognize the tension and can, The most important thing is only a light tension.
So low load.
Not low load, yes, that's right. Thank you.
Any other questions? Thank you.
Thank you.